Hello and welcome to our EBAC accredited webinar for the ISCP's A to Z of Cardiovascular Pharmacotherapy series. So today's program, we've got an exciting session for you, which will focus on Nebivolol, no limb pain. And for those of you that don't know me, my name is Satiris Antonio. I am a consultant pharmacist for cardiovascular services based in London. And it's with pleasure that we are joined today by a fantastic faculty. We've got Professor Sang Hong Baek, who's an emeritus professor at the Catholic University of Korea and also president of the International Society of Cardiovascular Pharmacotherapy. We've also got Professor Christoph Filipiak, who is a professor of cardiology and deputy rector for internationalization, promotion and development at the Medical University of Warsaw, and he is also president-elect of the Polish Society of Hypertension and past chair of the Polish Cardiac Society Cardiovascular Pharmacotherapy Working Group.
Nice to meet you.
And we also have Professor Bernard Chung, who's an honorary clinical professor at the Department of Medicine, University of Hong Kong, Queen Mary Hospital, based in Hong Kong.
Hi, everyone.
And unfortunately, due to unforeseen circumstances, Dr. Ozzy Saikan won't be able to join today's session, but we do wish her a quick recovery. So as a reminder, today's broadcast is supported by the International Society of Cardiovascular Pharmacotherapy and brought to you by Radcliffe Cardiology. This is to be an interactive session, which will feature a 10-minute live audience Q&A segment. So please do feel free to submit your questions to the faculty via the question module on the webpage, and we'll endeavour to answer as many of those possible towards the end of the broadcast. So I'd now like to hand over to Professor Baek, who's going to present Nebivolol, no limb pain. Thank you very much.
Thank you for your kind introduction, Mr. Satiris. Good evening or good morning, ladies and gentlemen. It is my privilege and a pleasure for me to be here as a speaker. The title of my talk is Nebivolol, no limb pain or no erectile dysfunction. This is my disclosure. Propranolol, as a first generation of beta blocker, was synthesized by Dr. Black. New drugs of this class have been developed. First generation non-selective beta blocker target both beta 1 and beta 2 adrenergic receptors. Second generation selective beta 1 block cardio-selective drugs are more favorable side effect profiles. And the third generation vasodilatory beta blocker shows better hemodynamic profiles with a few unfavorable metabolic side effects, such as labetalol, carvedilol, and nebivolol. Situated on the cardiac sarcolemma, beta 1 receptor is a part of the cyclase system and one of a group of G protein coupled receptors. By antagonizing of a beta adrenergic receptor, beta block interfere with the regulation of activated sympathetic nervous system and the renin-angiotensin system. A beta blocker reduces the intracellular cyclic AMP and PKA levels, followed by a decrease chronotropic and lucitropic and inotropic in the heart. While the vasodilatory properties of carvedilol and labetalol are mediated by alpha adrenergic receptor blockade, the nebivolol exerts this effect by increasing endothelium-derived nitric oxide by a stimulatory effect on enos mediated through beta-3 agonism. This slide shows the classification of a beta blocker according to the beta receptor selectivity and the presence of a vasodilatory effect. A cardio-selective agent exerts anti-hypertensive effects equally to the non-selective ones. A selective agent are preferable in patients with chronic lung disease or chronic smoking and diabetes. Cardio-selective varies among agents but is always great at low doses. No beta blocker is completely safe in the presence of asthma. In vasodilating beta blocker, carvedilol and labetalol via alpha blocking effect. In case of nebivolol, has a nitric oxide production. These agents might have added value in the control of blood pressure by achieving vasodilation. This slide shows the overview of effects of nebivolol on the heart, the kidney, and vascular system. Nebivolol exists on the both L and D in atomic imers, so two isomers. D-nebivolol antagonizes the beta-1 adenosine receptor in the SA node and the myocardium. In SA node, this agent slows down the conduction velocity of action potential and hence leads to decreased chronotropy. In myocardium, the resulting decrease in intracellular calcium and reduce the calcium reserve in cytoplasmic reticulum leads to negative inotropic and residuotropy. Beta-adrenergic receptor blocking in the JG apparatus in the kidney leads to the decrease in the renin release, which inhibits the activation of RAS system. L-nebivolol induced endothelial nitric oxide release is mediated by a different mechanism that causes vasodilation. And finally, antioxidation of nebivolol is due to a reaction of nitric oxide with superoxide. Nebivolol is metabolized in the liver through glucuronidation and via cytochrome P450 enzyme, cytochrome 2D6. The therapeutic effect of nebivolol has been reported to be independent of varying bioavailability, which is attributed to its active metabolite. The main route of excretion is through feces and urine. The indication of beta block and the US FDA approved drug from ischemic heart disease, hypertension, arrhythmia, heart failure, cardiomyopathy, the cardiovascular indication, central indications such as anxiety and thyrotoxicosis and the GI system and local use of glaucoma. Nebivolol is approved for the treatment of the hypertension in the United States. And for the hypertension and heart failure, especially heart failure reduced ejection fraction in Europe. In 2018 ESH guideline, beta blocker has a class 1 and level A recommendations as an anti-hypertensive drug, but not recommend first-line use of a beta blocker. And second one is hypertension is a specific clinical situation, such as angina, post-myocardial infarction, heart failure, or heart rate control. A beta blocker also has a class 1 and a level B recommendations. If blood pressure is not controlled with 3 drug recommendations, 3 drug combinations, beta blocker is one of the options as an add-on therapy to control blood pressure optimally. This paper is a meta-analysis on the use of nebivolol for heart failure treatments. They use many clinical trials, and finally, it's a 34 randomized and double-blind clinical trials. The total study population is almost 12,000 patients. In case of systolic blood pressure management, nebivolol was superior to other beta blocker and diuretics, and shows no difference in efficacy when compared with ARB and CCB. For diastolic blood pressure control, nebivolol was more efficient than other beta blocker, ARB, diuretics, and CCB. The conclusion of this meta-analysis was that nebivolol demonstrates at least similar control of blood pressure levels in hypertensive individuals when compared with the other blood pressure lowering class. According to 2021 ESC guideline, a beta block is recommended for patients with a stable heart failure with a reduced ejection fraction for reduced cardiovascular outcome with class 1 and level A. In the larger panel shows evidence-based dosage of this disease-modifying drug in randomized clinical trial in patients with heart failure with a reduced ejection fraction. In carbidopa, the prescription is a twice-a-day system. And in Nebivolol, there is a once-a-day prescription. However, Nebivolol has a treatment not shown to reduce cardiovascular or all-cause mortality in patients with heart failure. Recently, there was a four pillars of heart failure with reduced ejection fraction: RNA, and the beta blocker, and the MRA, and the SGL2 inhibitor. Beta blockers still remain very clinically relevant information. Senior studies means the study of the effects of a Nebivolol intervention on outcome and rehospitalization in seniors with heart failure. This senior study was a large, randomized, placebo-controlled clinical trial in elderly patients with history of heart failure aged older than 70 years, regardless of LV ejection fraction. Mean duration was follow-up was 21 months, and the mean maintenance dosage of Nebivolol was 7.7 milligram. In primary outcome, the hazard ratio was 0.86. P value was 0.0939. However, there's no difference in Nebivolol treatment versus placebo group in mortality. This demonstration of a significant lower risk of all-cause mortality or CV hospitalization in Nebivolol treated patient versus placebo. However, these benefits may be restricted to the patient with heart failure, reduced ejection fraction. Erectile dysfunction is a highly prevalent in men with cardiovascular disease, often precede a cardiovascular disease event by 2 to 5 years. And erectile dysfunction is a mark of general vascular disease. Some cardiovascular drugs, such as beta block and diuretics, have a deleterious effect on erectile function. We should be aware of these adverse effects in daily clinical practice. Nebivolol has at least a neutral effect to erectile function. That means RAS blockers of Nebivolol having the best profiles for quality of life. Here's the four major mechanisms of beta blocker side effects are smooth muscle spasm, bronchospasm, and cold extremities. Exaggeration of cardiac therapeutic actions, bradycardia, heart block, excess negative inotrophic effect, CNS penetration, insomnia, and depression, and also adverse metabolic side effect. However, the mechanism of fatigue is one of the frequent side effects of a beta blocker is not clear so far. Here's the contraindication of caution of a beta blocker from cardiopulmonary, CNS, and diabetes to the dyslipidemia. As mentioned earlier, if erectile dysfunction may occur, check for diuretic use and consider change to Nebivolol or AC inhibitor or ARB. In case of a metabolic syndrome or prediabetes, beta blocker may increase blood sugar and impair insulin sensitivity, especially with a diuretic therapy. So we should consider use carvedilol or nebivolol. This slide shows a summary of use of a beta blocker in current cardiovascular disease. Approved indication including heart failure, post-MI, and arrhythmia, and angina, hypertrophic cardiomyopathy, hypertension, and metabolic syndrome. Data for post-infarction protection and for mortality reduction in heart failure particularly impressive. However, other data are less compelling. In case of hypertension, beta blocker is not a first-line choice for general uncomplicated hypertension, but for selected hypertension. Among beta blockers, the ideal agent might have simple pharmacokinetics and a high degree of cardio-selectivity. Nebivolol has a high selective beta-1 blockade because, and a third one is a long duration of action. Nebivolol has a long duration of action, and the elimination of half-life is almost 12 hours. However, in this situation, it depends on the difference. For example, in case of a heart failure, reduced ejection fraction with a low blood pressure patient, we should consider use carvedilol because it has a twice-day prescription. And finally, the beta blocker has a favorable metabolic profile associated with vasodilated properties, such as nebivolol. The limitations in interpreting nebivolol trial data comes from absence of a CV outcome trial in hypertensive patients. In the senior trial, the minimum follow-up period of 6 months was extended to 12 months by the steering committee due to an unexpected low rates of the combined primary events observed in the blinded analysis. This extension of the observation window was interpreted by the advisory panel of US FDA as a potential source of bias. Nebivolol was not granted US FDA approval for treatment of chronic heart failure, despite the fact that it is used for the purpose of in numerous other countries. It depends on the regulatory policy by the country. Ladies and gentlemen, let me talk the take-home message. Nebivolol is a highly selective beta-1 adrenergic receptor antagonist with a peripheral vasodilating properties mediated by nitric oxide. Nebivolol might be related to its benefits observed in erectile dysfunction with a hypertensive patient or other beta blockers. Nebivolol shows a similar controlled blood pressure level in hypertensive individuals when compared with the other blood pressure lowering drug. Nebivolol given in senior trial to old patients higher than 70 years with a history of heart failure, regardless of ejection fraction or ejection fraction lower than 35%, reduced primary composite endpoints of all cause of mortality and severe hospitalization. Thank you for your attention.
Thank you very much, Professor Back, for a very thorough presentation on both beta blockers and nebivolol in particular. Just as a reminder, we will have time for questions after this next discussion segment. We've got a couple of cases to present, but just as a reminder, please do keep submitting your questions and we'll cover as many of those possible later in the broadcast. So we'll move on now to the case presentations. Okay, so we've got Mr. AB. He's a 61-year-old Asian gentleman, and he's had high blood pressure for approximately 25 years, and he was referred back to you for uncontrolled blood pressure. He's had treatment for 4 years, and you can see his stressful job as a civil engineer, and he's physical activity, in terms of physical activity, he walks lots of places, a couple of miles a day. On further investigation, he's got no history of chest tightness, dizziness or palpitations, and you can see that his family history, his father had a myocardial infarction at 72 years of age, and his mother had a stroke at 54 years of age, and his heart sounds were normal and his chest is clear. But you can see that his clinic or office blood pressure is 208 over 131 with a heart rate of 90 beats per minute. So what we've done is, in line with both national and international guidelines, is we've done a 24-hour ambulatory blood pressure, and you can see over the 24 hours, it comes across as 188 over 111, but his heart rate is 100 beats per minute. And his daytime average is 197 over 117 with a heart rate of 101 beats per minute. And a nighttime average, almost what you want as a daytime average, of 134 over 76 with a heart rate of 94. And you can see he's got that nocturnal dip that we'd like to see. So we've excluded secondary causes of hypertension. We've done a 24-hour urine electrolyte assessment, and you can see he takes approximately 6 grams of salt per day, and he's got an echo of 65%, and you can see his blood pressure's there. In terms of his treatment, in terms of his treatments, you can see that he's now stabilized on amlodipine 10 milligrams daily, indapamide 1.5 milligrams daily, and losartan 150 milligrams daily. And you can see he's had some intolerances there with beta blockers and verapamil. And you can see here that we've managed with those 3 triple therapy combination of observed office blood pressure or clinic blood pressure 150 over 90, heart rate still above, quite high at 95 beats per minute, and his aim blood pressure is 145 over 88 with a heart rate of 90 beats per minute over the past 6 months. So perhaps we can go back to the panel. If we start with Professor Filipiak, any thoughts on this individual case?
Well, I think it's an ideal candidate for Nebivolol, because you had the information that he had erectile dysfunction after bisoprolol. We have even a special consensus of experts of European Society of Hypertension stating that Nebivolol is a beta blocker of choice if we need a beta blocker. And we do really need a beta blocker in this case that you have presented, because this patient has tachycardia. He has tachycardia of 90, as I remember. Even during the day it was 100, in the night it was over 90 beats per minute. I just want to remind you that from one point, of course, as we had in our first lecture, we should start the treatment with 2 antihypertensive drugs which are not beta blockers, and the third drug is not beta blocker still, but in description of this algorithm to European Society of Hypertension, they are saying that you can use beta blocker in a first line. So you can use a beta blocker as a first line antihypertensive if a patient has tachycardia. So this is the case. So in fact, in this patient, I would start, I don't know, with sartan and Nebivolol, or AC inhibitor and Nebivolol. Then I would add calcium channel blocker, and then I would add indapamide probably. So he will end in 4 drugs at least, as I feel clinically. And maybe one more sentence to add. We have been listening to this great lecture at the beginning of our meeting, and you have heard that in all over the world, Nebivolol is registered in arterial hypertension. I'm from Europe, so of course in Europe, it's also recommended in recommendations in guidelines for heart failure. We are not in USA, so heart failure, but also in my country, in Poland, for example, Nebivolol is also registered on a regular basis in chronic coronary syndrome, so in stable angina. So in fact, Nebivolol can be used in arterial hypertension, in heart failure, in coronary syndrome. So for this man, Nebivolol is a very good choice. And maybe the last thing I want to add, we, in my country, I don't know how it's in your countries, but probably the same, that we have standard doses formulations of Nebivolol 5 and 10 milligrams. But if we move to USA, for example, they have Nebivolol 10 and 15 milligrams in one tablets. So nowadays we really know that bigger doses of Nebivolol probably are more hypotensive and have more pleiotropic action. That would be my commentary.
Thank you very much. And just before we go to Professor Chung for any other comments, as a reminder, please do submit your questions and we will try and touch those after the cases. Professor Chung, anything you wish to add with this individual case?
Thank you very much, Soterios. There really is not that much to add because the two previous speakers have really emphasized all the main points. Now, I manage patients in Asia, in Hong Kong in particular, so this 61-year-old Asian gentleman is very typical of the patients that I see every week. For those who are who are not familiar with the Asian hypertensive patients, they're more likely to have the metabolic syndrome. In addition to hypertension, they may very well have either diabetes or prediabetes, or they have high triglycerides and low HDL, perhaps some abdominal obesity as well. So that's very typical of the patients we see. And the other thing about Asian patients is that they respond quite well to calcium channel blockers and diuretics. Now, in this particular gentleman, AB, he was already on amlodipine, whacking those 10 milligrams daily, and also on indapamide already. So these are, good choices for the treatment of patients with hypertension. The problem with amlodipine, of course, it causes quite a lot of edema. So I think 10 milligrams is just about the, higher dose that you can use. So the obvious choice here to add the fourth drug, A, B, C, D, the B is missing. So beta blocker is the obvious choice. And amongst the various beta blockers, Nebivolol must now be one of the forerunners for a variety of reasons. I think these have been sort of mentioned by Professor Bach and also Professor Filipiak. But to summarize, Nebivolol is beta-1 selective, but at the same time, it's also vasodilating. So it's rather good because you worry about if you're worried about cold extremities. I understand in London it's still pretty cold at the moment, but it's very warm in Hong Kong. So in colder countries, then you want a vasodilator, and also I want to draw attention to the metabolism. It's not just renally excreted; it's also metabolized. So which means that even if your renal function is not very good, or if you have drug-drug interactions that may affect 2D6. Or perhaps you're genetically deficient in 2D6. It's not drastic because the drug can still be got rid of either through the urine or by metabolism, or actually the feces as well. So that is the reason why Nebivolol is a very good choice. And lastly, and not least, Nebivolol has been around for a long time, so it's got a very good safety profile. It's not a brand new drug we know nothing about, so we know its safety profile very well, and also it's generic, so it is very cheap to use. It's not going to break the bank. So that is why I think Nebivolol is a good beta blocker to use, and would be my choice as the fourth drug for this particular patient, AB. Over to you, Chairman.
Thank you. And what I might do is take Chairman's privilege and just bring in some of the questions that have come through as part of this. You sort of touched on a bit, but one of the questions was around, are there any racial or ethnic differences in the response to beta blockers, or should any type of patients that we want to take into consideration when we're prescribing these medications? Can you touch on a bit more and elaborate around some of the racial considerations for beta blockers? Are there any patients that you feel in your experience in prescribing beta blockers or other agents you may find may not be suitable, or are there examples where you think Nebivolol will be in particular taken into consideration?
Is the question for me?
Yes, just touching based on what you mentioned.
Right, okay. Well, I'll carry on a little bit about drug metabolism. Nebivolol is metabolized by 2D cytochrome P450 2D6. And some people, maybe about, I don't know, about 10%, 15% of the population has low levels of this enzyme. Now, it matters relatively little, whether patients are on Nebivolol or not, because Nebivolol is also renally excreted. But for metoprolol, which is a very popular, widely used beta blocker for treatment of hypertension and heart failure, if you are deficient in 2D6, then your metabolism is slower, and therefore you can only take you're very sensitive to even small doses of metoprolol. And for these patients, a normal dose of metoprolol can cause bradycardia. And so they take a quarter, half dose of metoprolol. But I think with Nebivolol, we don't need to worry about that too much. Other racial differences, diuretics are said to be the drug of choice for people of African origin. So that's something that one ought to consider, whereas they are said to be less responsive to ACE inhibitors. And I'm sure my co-speakers will have something to add about their own experience of ethnic differences in response to antihypertensive drugs.
Thanks.
Yeah, so maybe I will add something. Well, of course, I'm as a cardiologist and medical doctor, almost all my patients are of Caucasian race, and in this race, let's say I would say that Nebivolol up to 10 milligrams is okay, and I have good clinical experience with such dose of Nebivolol. But as you know, American Heart Associations and American Hypertension Society, when they issued last guidelines and last recommendations on antihypertensive, you will find in a table when they are talking about Nebivolol that the maximal dose of Nebivolol is 40 milligrams. It's not a mistake, 40 milligrams. So it's 8 tablets, 5 milligrams Nebivolol, 40 milligrams. And when I looked at it first time, it was several years ago because it was published 2017, as far as I remember. I talked with some of my American colleagues, cardiologists, and I asked them why they put such a maximal dose of 40 milligrams Nebivolol. And the answer that was given very often was that it's because of Afro-American citizens in USA, in which they usually need more doses of Nebivolol to reduce heart rate, or to get a hypotensive response. So based on this, I think that in the Afro-American race, probably these doses of Nebivolol should be a little larger.
Thank you very much for the comments on those. Let's
Mr. Sotio,
please
can I make a comment on this case?
Please
thank you. This case is a stressful Asian hypertensive patient. So one of my general comment is we should know the height and body weight information about this patient. And the second one is we should investigate the presence of hypertensive target organ damage. And the most important thing is what's condition of treatment compliance, because sometimes a very stressful condition is forgot to regularly take their own medication. And lastly, in case of a urinary some sodium contents, according to my experience, I usually check the spot urine, the sodium potassium ratio, because the spot urine sodium potassium ratio less than 1 is very much some healthy parameter. That's what I comment. Thanks.
No, that's very, very helpful. Very helpful. If we proceed to the next case, and then we can think about some of the other questions coming through the panel. So here we've just got the one slide, and we've got a patient EF who is a patient with heart failure with reduced ejection fraction. So the information we've got here is a 75-year-old gentleman. He's got type 2 diabetes, where he was diagnosed 2 years ago. And then more recently, he's had heart failure with reduced ejection fraction, diagnosed 3 months ago. His current signs and symptoms, he is New York Heart Association classification stage 3, so shortness of breath even whilst walking, but also more towards at rest, and ongoing fatigue. And his comorbidities are he's got some obesity, BMI of 32, hyperlipidemia, and ongoing hypertension. His other measures, he's got in EGFR, so his renal function, he's got a creatinine clearance of 55 mils per minute based on an EGFR, and his left ventricular ejection fraction is 35%. And in terms of his current treatment, you can see he's currently on diuretics and on an ACE inhibitor of ramipril 5 milligrams daily. Type 2 diabetes and metformin, and hyperlipidemia, he's on atorvastatin 20 milligrams daily. So quite a lot of information there, newly diagnosed with heart failure with reduced ejection fraction. And now you can see in terms of that secondary prevention, he's just on an ACE inhibitor with ramipril 5 milligrams daily. So perhaps if I can start with Professor Chung in terms of considerations, and this is quite a more holistic case with heart failure, I'd welcome your thoughts as to how we can consider some of the optimizations for this gentleman, 75 years of age, recently diagnosed with heart failure with reduced ejection fraction.
Thank you, Sotiris. Well, just looking at the list of drugs there are some additional drugs that ought to be considered and perhaps introduced. I think probably the oldest one to introduce, and maybe the first one to introduce, would be a beta blocker. And the reason is because beta blockers will reduce mortality. So that is quite important. Also, you need to start from a low dose and build up the dose. So you want the blood pressure to be quite good before you start the beta blocker, because as you add more drugs, the blood pressure will come down even more. And as for which beta blocker to use, well, the choice includes cardio-selectivity, metoprolol, bisoprolol, and Nebivolol. These are in the countries where it's approved for the treatment of heart failure with reduced ejection fraction. But of course, in recent years, we know that there are other new drugs which ought to be considered, and these include spironolactone. I'm kind of talking into the historical chronological order. So spironolactone, and then entrastane, which is a combination of an ARB, valsartan, with a sacubitril, which is a neutral endopeptidase inhibitor. So that has been shown to be of value and of benefit to people with reduced ejection fraction. And then very recently, in the last couple of years, we have now known that the SGLT2 inhibitors, such as dapagliflozin and empagliflozin, are highly effective and beneficial in patients with heart failure. Not just heart failure with reduced ejection fraction, but for the first time, even those heart failure patients with preserved ejection fraction will benefit from an SGLT2 inhibitor. So quite a few drugs to be introduced in this patient. And in practice, the question is, which to go first, and also whether the patient will tolerate, particularly, whether the blood pressure may not be decreased too much. Now, SGLT2 inhibitors have the additional advantage of treating not just the heart failure or the hypertension, but also his diabetes. It would improve the diabetic control, but also help him to lose weight since he's said to be obese. So it's not killing two birds with one stone, but killing several birds with one stone. So I think this patient will benefit from additional drugs, of course, also with other changes in lifestyle as well, such as healthy diet, regular exercise, reducing salt in diet, stopping smoking, etc. Okay, so I think I'll stop there because I'm sure there'll be other pearls of wisdom from my fellow speakers. Over to you, Chairman.
Thank you. Professor Filipiak, anything you wish to add for this case?
Yeah, I treat a lot of such patients. In every week, I see 20, 25 patients with heart failure. And of course, I must, as a European cardiologist, I must follow European Society of Cardiology guidelines. And in all these patients, I need to introduce 4 classes of drugs. So there are 4 essential columns. And if I do not follow guidelines, if I don't give such one column even, I do something against guidelines here, because it's in a first class and a level of evidence is A. So in this patient, as a first drug, I must give AC inhibitor or sacubitril/valsartan. I know that sacubitril/valsartan has a little higher evidence level nowadays, but as you remember, its superiority is proven only when you compare it with enalapril. So in fact, in my country, we rather give AC inhibitors. The second reason is that sacubitril/valsartan is not reimbursed in my country, so we usually give AC inhibitor, but really I would like to give sacubitril/valsartan in more and more patients. In second column, of course, I will give him dapagliflozin or empagliflozin. Every patient in my country in heart failure receives these drugs, only those 2, because only those 2 are registered in heart failure. And of course, it doesn't matter if a patient has diabetes or does not have diabetes. It doesn't have anything to do. Every patient with heart failure must receive flozin. The third drug will be beta blocker. And of course, for me, the drug of choice in this group, in this particular patient, would be Nebivolol. Why? Because when you consider seniors clinical trial, you could come to the conclusion that Nebivolol is the only beta blocker which was well evaluated in people over 70 years old. So therefore, it's my preferential beta blocker in this particular patients after 70 years of age. And of course, the fourth column are aldosterone antagonists. And in my country, of course, such a patient wouldn't be recommended spironolactone. We are not prescribing spironolactone, especially to male patients. He will receive in my country eplerenone as a drug of choice. So eplerenone is a standard of treatment. And one more important thing, you have presented us a patient with arterial hypertension as a concomitant disease. And that is something I'm really very glad, because all those patients with concomitant arterial hypertension are better patients when you treat heart failure. So you can introduce 4 drugs at the same time. You cannot be afraid of hypotension. It's even better to start with low doses, but of all 4 drugs. Of course, not flozin, because flozin you are giving 10 milligrams of empagliflozin or dapagliflozin. It's a dose that you give that is a final dose and the beginning dose. But all the rest you can start with a little dose, but at the same time. So I think this is the most important take-home message, that you must give all 4 drugs. at the same time, if it's possible in such patients. And of course, this patient will also follow your other recommendation, and atorvastatin, and maybe the fifth drug, I mean diuretic, if he has any signs of retention. We remember diuretics does not prolong life in heart failure, but are also the fifth column, let's say, to reduce the retention of fluids on them. So that would be my comment.
Thank you very much. And before I go to Professor Bayek, there's really good evidence in arterial hypertension that by adding in other drugs, you get a bigger reduction in blood pressure, which hopefully supports the additional benefit of going with the 4 pillars, even at lower doses acutely, just to give you that return of investment. Professor Bayek, is there anything that you wish to add? And there has been some questions that we...
Yes, thank you. Thank you for. So in this case, I wonder what's the etiology of heart failure reduced ejection fraction, ischemic or non-ischemic, and in case of some popular system, most Asian has some high incidence of side effect of AC inhibitor, such as dry coughing. So we prefer to use ARB rather than AC inhibitor. But after introduction of RNA to save the some broken heart, so problem is it's a little bit expensive one compared with other ARB or AC inhibitors. So in the regulatory agency has very much a strict indication for money reimbursement according to the pharmacoeconomic issues. The second one is in case of a beta blocker, which one do you choose? Just it depends on the patient's condition. As mentioned, I already mentioned earlier, heart failure, reduced ejection fraction with a low blood pressure patient. We prefer a little bit short duration of beta blocker rather than long duration of a beta blocker. It's just some carbidopa versus nebivolol. But however, the heart failure with reduced ejection fraction, with high blood pressure or tachycardic patient, we can choose bisoprolol or metoprolol succinate and nebivolol. We have a lot of choice over there. Another one is, so according to the guideline, there's a 4-pillar system. However, in the practical issue, how to choose which one is the initiation, step by step, or some combination initiation and followed by another combination, or some people prefer to use 4-pillar, some simultaneously together with a low dosage and some titration. There is some unsolved questions, so we should find out according to the some in clinical trial in the future. Thank you.
Thank you very much. We'll move on to some of the questions from the audience, if I may. And one of the questions that comes up is, we've always been taught with beta blockers and people with peripheral vascular disease or Raynaud's syndrome, but Professor Bayek presented the benefits of nebivolol having some vasodilation. Can anyone bring forward some experience and safety of using nebivolol in people with Raynaud's or peripheral vascular disease? And if so, how would you introduce nebivolol?
According to the some, can I?
So please.
Yes. According to the some small clinical trial, nebivolol has some beneficial effect over there, but it is not easy to generalize the some that kinds of issue. Some people some produced some clinical data, the efficacy of nebivolol in the vasospastic angina or peripheral artery disease or Raynaud's syndrome or such like that. In this case, we should try some clinical trial to make some strong evidence. So far, it is not easy to say the efficacy of nebivolol in that case of disease. I'm not sure. How about the Professor Christophe or Professor Bernard? Please tell us your opinion about this tough question.
Well, of course, we agree with you as far as evidence base of medicine is concerned, but from clinical point of view, if I had a patient with arterial hypertension and concomitant peripheral artery disease, or heart failure and concomitant peripheral artery disease, and I have to give a beta blocker to those patients, well, in fact, I have two choices. I have a choice of Nebivolol or a choice of Carvedilol. So I will always use one of the vasodilative beta blockers. But in majority of patients, nowadays from those two, I will rather consider Nebivolol, not Carvedilol, because when I compare Nebivolol and Carvedilol from practical clinical point of view, this alpha beta blocker component is very good as a hypotensive beta blocker, but it will even at larger doses increase heart rate. So Nebivolol will not increase. It will decrease, maybe not to such an extent as bisoprolol, for example, but it's rather more beneficial as far as heart rate is concerned than Carvedilol. Therefore, in many patients, I would decide for Nebivolol, not for Carvedilol. And one more very important thing for me, not from clinical, but from pharmacological point of view, is that there is a totally different mechanism of vasodilation, as we remember, in Carvedilol and in Nebivolol. In Carvedilol is just, let me say, just stupid pharmacological alpha-beta blocker, like labetalol. For me, Carvedilol is just a modern labetalol, nothing more nowadays, yeah? And in Nebivolol, it's just a question of not beta-1 blocker, but beta-3 adrenomimetic. So when you really go to beta-3 receptor, you will induce endothelial nitric oxide synthase. So from pharmacological point of view, you could say that Nebivolol is acting like statin or AC inhibitor. So in fact, these are the same drug as far as you look at the endothelial dysfunction. So my choice, once again, in summary, for nowadays in this peripheral artery disease is not Carvedilol, but rather Nebivolol.
Thank you. Professor Chung, if I can turn to you, you mentioned about the CYP2D6, and there's been some questions around the potential drug interactions with Nebivolol and how these should be managed. Are there any common interactions that you are aware of, or things that we should just have in the back of the minds when we're prescribing Nebivolol in case of concomitant medications?
I think I mean, obviously, there are charts that one can look up, to see if the two drugs are interacting. But as I said earlier, there is a safety mechanism there, in the sense that Nebivolol is also renally excreted. So even if the levels are high because of drug interaction and slowed metabolism through the 2D6, you still have the renal route of excretion. So I think that there's additional safety there. In fact, the biggest problem comes from, people that are 10% of the population who are either deficient or have low levels in 2D6. And we do observe that in clinical practice. Something like 1/10 of our patients, if you give them a metoprolol, they're very sensitive. The heart rate goes through. I've got some relatives who are like that. So, you give them heart failure dose, for hypertension. Now, I also want to, if I may, go back to about talking about ACE inhibitors and the cough inhalations that Professor Back mentioned. It's something, something very common in Asia. So much so that some clinicians would, prefer to use an ARB instead of ACI, because these ACE-induced coughs are so common, and very often you really can't be sure whether it's a smoker's cough or an ACI cough. But what it does, though, is it sometimes undermines the patient's trust in medicines, trust in the doctor. They experience this side effect, rather troublesome side effect from an antihypertensive medication, and then they are, frightened of all other, antihypertensive medications. So I think there's something, something to bear in mind when you approach a patient in the Far East. Now, another thing I completely forgot to mention, and I really need to mention it now, is if you do start a patient on Entresto, such as the first patient in case 1, you have to withdraw their ACI. You shouldn't be giving an ACI, or for that matter, an ARB together with Entresto. So I think that's something for clinicians to bear in mind. Thank you.
Thank you very much. Well, I'm afraid that's all we've got time for today. That time has gone very, very quickly. I'd like to remind you that today's proceedings will very shortly be available on demand, and that's on the website for radcliffecardiology.com. And as a reminder, to get more access to more content and learn about the opportunities offered by the International Society of Cardiovascular Pharmacotherapy, please do scan this QR code. That will give you far more information and more details. And it wouldn't be right to drop this webinar today without mentioning the upcoming annual scientific meeting in Seoul on the 23rd to the 25th. Professor Baek may wish to add a couple of words just to help support the exciting annual scientific meeting in Seoul.
Yeah, thank you very much. It's I lovely invite all of you with a warm heart join our incoming 28th ISCP meeting. This meeting will be held in November 23 to 25th at Seoul, Korea, the Conrad Hotel. Please check the homepage of our ISCP and find out updated information. And please join us and lovely enjoy the cake culture. Thank you very much. See you again.
Thank you. And before we go, I'd just like to remind you to keep in contact with the ISCP for the next webinar. And on that, I'd like to thank our fantastic faculty again for their fantastic contributions. So many thanks to Professor Baek for his wonderful presentation, and our panelists, Professor Filipiak and Professor Chung. Thank you very much. And to you, the audience,
thank you very much
for keeping with it. Thank you, everyone, and enjoy the rest of the day.
See you all in Seoul.
Yeah, see you again. Bye-bye.